We'll talk about chapter 11. These are the drugs for pain management. Pain is an unpleasant sensation or emotion that produces or might produce tissue damage. And we already know that pain is a subjective experience. This is something that the patient tells us as nurses, and we cannot measure it. But one important rule to remember about pain as nurses is that pain is whatever the patient says it is, occurring whenever the patient says it occurs, and at the intensity that the patient states. What does it mean? It means that when a patient tells you, nurse, I'm in so much pain, can I please get my pain medication? As nurses, you are expected to believe that and you are expected to act on it. Pain is classified either acute or chronic. For your acute pain, this is usually related to something that is within an expected time frame. So for example, maybe you bumped your head or you cut your finger or surgery or trauma or even infection. It's expected to end within a time frame. And acute pain triggers the what we call the fight or flight response because your body is trying to adjust to that painful sensation. With chronic pain is any pain that continues beyond the expected time frame of an acute injury process. Some studies say it's 6 months, but really chronic pain is something that is occurring for way too long, that your body has adapted to it already. It's actually not responding. Your fight or flight response is not actually being activated anymore because your body adapted to it. Factors that produce pain. We already know that pain is an unpleasant stimulus. So it starts with that area that you injured, and then it will travel through those nerves, the firing of those nerve endings, and then those electrical activity. It will signal from that area of injury. It will go along the nerve endings to the spine, and then from the spine, it's gonna go all the way to the brain. And then once it reaches the brain will interpret that pain. And then the brain will tell you either activate the fight or flight response, or the brain will ask you to do movement. Like, let's say you cut your finger, you're going to move that finger away from that painful stimulus. Before we start talking about the medications for pain, let's look at your page 212, which is the table 11.1. These are the classifications of pain, the category characteristics, and some examples of the pain. So again, we already know acute, it's sudden onset and it's short term. Samples are your surgical pains, your traumatic injury, bone fracture, or infection. For your chronic, we already know that it's a long term and it bypassed that time frame of the acute pain process. Some examples are your arthritis pain, sciatica, shingles, and then now you have your continuous. When we say continuous, it's always present. It may vary by intensity, but it's always there, it's always present. One example is your sciatica. And then we have intermittent. It comes and it goes, right? One example is your abdominal cramping from constipation or intestinal irritation. You also have your nociceptive. This one is specific to a body area that is easy to identify and describe. Examples are your cuts, fractures, arthritis. And then we have visceral. Visceral, when we say visceral pain, this is hard to locate because this is what we call, if you recall, your referred pain. That's it's originating from one area, but then the pain you feel it somewhere else. So one example is the pain under the right shoulder blade when you have gallstone disease. And then you have neuropathic. Again, like I keep telling you guys, whenever we talk about neuropathic, we're talking about nerve pains. We're talking about the damage in the nerve. So the characteristics of your neuropathic pain, you have your sharp, shooting, stabbing, and burning sensations. And examples are your diabetic neuropathy, your trigeminal neuralgia, or your pain with the shingles. And then we also have cancer pain. This often includes all specific types of pain with multiple causes. Samples, well, very obvious. This is pain that we feel when we have cancer. Okay, now if you look at your page 213, there are some measurement scales that we use as nurses when we're trying to measure the pain of our patients. So the first one that you see in the top, that's the numeric pain scale, right? You're gonna ask your patient, can you please rate your pain? 0 being no pain, and then 10 being the unbearable pain. So that is your numeric pain scale. And then we also have the what we call the face measurement scale, where you're gonna see that the face with the smiling is no hurt, and then the face with crying is the one where it hurts the most. So for this one, when do we use it? We can use it for those patients that are maybe confused, or you can use it for those patients that maybe have communication barrier. We also have the Wong-Baker, right? Faces pain rating scale. In the bottom, you're gonna see it. There's like 5 categories. You're gonna look at their face. You can do they have expression or smile, or are they grimacing? Are they frowning? Are they smiling? Right? And then you're gonna look at their legs. Is it in a normal position? Is it relaxed? Or is it uneasy or restless? Or are they kicking because of too much pain? Then you're going to look at their activity. Again, you're going to see if they're, sitting quietly, or are they like squirming, or are they arched or jerking. You look also if they're crying, right? There's no cry, or are they moaning or whispering, or are they crying or screaming or sobbing because of too much pain. And then you look at the consolability. Are they contented? Are they relaxed? Or do you have to reassure them by occasionally touching them or talking to them or distracting them? And or you're gonna see if they are difficult to console or comfort. Okay, so for medications that we use for pain management, we have some miscellaneous drugs, or what we call it analgesics, that we use, analgesia, for pain management. We have your non-opioid analgesics, which are your acetaminophen, your corticosteroids, your NSAIDs. We even use some skeletal muscle relaxants, and even antidepressants and anticonvulsants. We can use them to manage the pain. But let's start talking about those opioid medication that we use for drugs. So 3 types. We have the agonist, we have the partial agonist, and we have the agonist antagonist. And what do they mean? So So for your agonist, this binds with the receptors to activate and produce the maximum response of the individual receptor. And then for your partial agonist, this produces a partial response, partial only. For your agonist antagonist, this acts as an agonist for some types of receptor, and then it acts as antagonist at another type of receptor. Let's look at your book at page 215, your table 11.3, so we can look at some common opioid agonists. So you have your codeine, you have your fentanyl, your hydrocodone, hydromorphone, morphine, oxycodone, and your oxymorphone. So during MedSearch 1, we already talked about the two main side effects that we usually monitor when we're giving opioids, which is your constipation and the decreased respiratory rate. So those are the two things that we always look for when we're giving opioids. But we're going to go over some more nursing implications so that we can understand some more side effects and some more education that we need to do when we're giving these medications. Okay, so the first one, after you give the medication, you reassess the patient's level of pain within an hour to make sure that your intervention is working. Second one, during the periods of acute pain, you encourage the patient to take the drug on the prescribed schedule for best pain relief. What does this mean? It means that you tell your patient that they should ask for their medication or they should take their medication before the pain gets to that threshold where it's unbearable already. So as soon as they start the pain, and the pain medication is already scheduled that they can take it, then they should take it before they would even go to that pain level where it's unbearable already. Number three, we assess respiratory rate. We already know this. We do our pulse oximetry frequently because opioids can cause respiratory depression. And then four, if patient cannot be aroused, if you see that the respiration is very low, if you see that the blood pressure is very low, then or the temperature, hypothermia, you notify the healthcare provider immediately to prevent coma or death. And then again, going back to the constipation, you're gonna have or you're gonna get an order for the patient to take a laxative, right? Because of the high incidence of constipation common with opioids. And then of course you tell your patient not to drink alcohol. We already know that because it's gonna depress the CNS. So combining it with alcohol is not going to, it's gonna intensify the CNS effects. Now the last one, let's talk about fentanyl. So fentanyl comes also in patches, right? And we already talked about when we give patient patches, you make sure that you rotate the sites. It's given every 72 hours. You wash the skin under the old patch to prevent excess drug absorption before you would even give it to another site, okay, after that 72 hours. Some keywords regarding pain management. You have your tolerance, your dependence, and your addiction. Tolerance, this is a drug-related metabolism problem that causes the same amount of drug to have less effect over time. So your patient that is getting, for example, morphine every day over time because they've been taking it for a long period of time, the effect of that drug produce a decreased effect already. It's losing its effect because your patient is now having that tolerance to that drug. That's what tolerance means. Dependence, this is a state in which the body will show withdrawal symptoms if the drug is stopped or reduced. And this is very common with your narcotics, with your opioids. Remember, opioids, they have a very high risk of dependency. So your patient that has been taking opioids for a long period of time, then if you suddenly discontinue it or stop it, then they will now show withdrawal symptoms because they're very dependent to that drug that they're taking. Addiction, this is the uncontrollable need to have and use a drug for non-medical reasons. Very straightforward. Opioid and agonist analgesics, we just talked about that. That's page 215 in your book. So what are their actions? The actions is to prevent pain perception in the central nervous system. It produces analgesia, stopping the pain, sleepiness, euphoria, unclear thinking, slow breathing, decreased peristalsis, reduced cough reflex, and hypotension. Again, we already know that those are the things that we look out for when we're giving the opioids to the patients. We use it to treat moderate to severe pain. So, moderate to severe pain. So, like for example, you're going to ask your patient, give me a scale of your pain. How painful is it? 1 being zero being the no hurt, and 10 being the most hurt. If they tell you, oh, it's in the 7 or 8 or even 10, then you can use your opioid to control the pain. Again, side effects, sleepiness, constipation, and don't forget your decreased respiratory rate. Adverse reactions. So you look for your bradycardia, your slow breathing, respirations of 8 or less per minute. Hypotension, low blood pressure, very low blood pressure to the point where your patient is fainting. Your anorexia, constipation, confusion, euphoria, your dry mouth, vomiting, pruritus, your itching, and skin rash. So for your pruritus and skin rash, you have to monitor them. Maybe they are allergic to this specific opioid that you're giving. Okay, before we move forward for the PCA, let's talk about um, the medication that we use to reverse an overdose for your opioids or your narcotics. So if there's an adverse reaction or an overdose that happens with your opioid agonist, the effects, they can be reversed by the medication called Narcan or naloxone. Okay, naloxone or other name is Narcan, or there's naltrexone or Revia, but the most common is your Narcan, your naloxone. Okay, so it can be given IV, IM, or there's even a spray now that's available to the nose. Okay, so I need you guys to remember that medication because that is what we use to reverse the overdose or adverse effects of an opioid. Okay, so let's go to the PCA. PCA, your patient controlled analgesia. That's why it's called patient controlled, because the patient is controlling the infusion themselves. Okay, this is used when a continuous infusion of opioids is required. There's a pump and it's calibrated to an ordered dose and frequency. The patient is able to self-administer the pain medication by pushing a control button. The pump can be programmed to deliver an hourly rate. Okay, so PCA, the patient will be connected to this pump, and when they feel pain, they will push that button so that the medication will be infused to them. However, even if the patient is pushing and pushing and pushing every 5 minutes, that doesn't mean that that pump is gonna give them that medication every 5 minutes. Okay, that pump is still calibrated to the ordered dose. So yes, the patient can still push the control button, but the pump is calibrated to only give the ordered dose. For example, if the pump is calibrated for every 3 hours, right? That's your frequency of the dose, right? And then your patient keeps pushing it every 30 minutes. Well, it's okay, they can push it, but the medication will be given when it is still dosed, or when it's time to give to the patient already. Okay, the patient don't know that. We know that as nurses, but the patient don't know. Okay, that's how a PCA works. That's how a patient-controlled analgesia pump works. Drug interactions. So we already know alcohol, right? It's always number one drug interaction for almost all of the medications that we've been talking about. So drug interactions, the decreased pupil size, sedation, dry mouth, and euphoria, those are your central nervous system effects of the opioid, and it can be intensified and made worse when the patient also uses certain other substances or drugs that acts on the CNS, just like your alcohol or your anti-anxiety drugs, your skeletal muscle relaxants, barbiturates, and then many drugs that we use for your psychiatric disorders, your antipsychotics that we talked about, or any other opioid agonist. Opioid agonist, antagonist, analgesia. So if you look at page 218, your table 11.4, those are the samples of your opioid agonist, antagonist, analgesics. So how does it work? The action, it acts on chemicals at specific nerve sites in the central nervous system, possibly in the limbic system. It blocks the mu receptors and changes the perception of pain by agonizing the kappa receptors. So it produces analgesia, euphoria, and respiratory and physical depression. We use it for moderate to severe pain. We also use it for pre-surgical anesthesia and for active labor. So let's look at it in page 218. You have your buprenorphine, your butorphanol, nalbuphine, and pentazocine. Nursing implications, well, let's go over the side effects. Side effects is sedation, constipation, and constricted pupils. Nursing implication, again, when you give the medication, after you give it, you assess again the level of pain within an hour after giving the medication. You assess the patient's emotional responses because this medication can cause dysphoria, anxiety, nightmares, and hallucinations because it works in the central nervous system. You assess the heart rate and rhythm frequently because these drugs can excite the cardiac system and can cause dysrhythmia. And then lastly, avoid the use of butorphanol and nalbuphine and pentazocine in a patient who is physically dependent on an opioid agonist because blocking the mu receptor can cause withdrawal symptoms. So if your patient is taking those opioid agonists or they're dependent to the opioid agonists, you make sure that you avoid this opioid agonist antagonist medication because it can block the mu receptor. It can block that receptor and it will cause withdrawal symptoms. Adverse reactions. You have your bradycardia or tachycardia. Remember, it was working in the cardiac system, right? It excites the cardiac system and it can cause those dysrhythmias. Hypertension or hypotension. There's going to be changes in the mood, confusion, nervousness because it acts in the CNS, your central nervous system. There might be blurred vision, dizziness, and headache, weakness, nystagmus, syncope, tinnitus, tremor, and unusual dreams. nausea, vomiting, dry mouth, and constipation. And just like the opioid agonist before, your opioid agonist antagonist analgesics also has a drug interaction or has an interaction when you take it with alcohol and CNS depressants, those medications or substances that people take to depress the CNS and relax it. Okay. Nursing implications in patient teaching, we just talked about that. Now let's look at the non-opioid centrally acting analgesics. So these are the drugs that work in the central nervous system to help manage pain, but they do not interact with opioid receptors, right? So that's why they call non-opioid centrally acting analgesics. So page 218, you can see the two most commonly used drugs in this class are your clonidine or Duraclone and tramadol, which is your Ultram. But we can also use some other medications, just like your acetaminophen, like your Tylenol. And now there's a lot of other brand names that is coming out under your acetaminophen. This is very common drug that we use for pain relief, and it's an over the counter, so you could just buy it in your regular drugstore. It acts only in the brain to reduce the production of the prostaglandins, a body chemical that can cause inflammation in other body areas. So it blocks the production of prostaglandin. That's how acetaminophen works. So, but one thing to remember for acetaminophen, there's always a maximum daily total dose to prevent organ damage, especially your liver. Okay, it's toxic to your liver if you go over that maximum daily total dose. Side effects of acetaminophen are rare when it is taken at the recommended dosages, but allergic reaction can always occur, and you can also have some side effects of nausea and skin rash. Continuing to miscellaneous drugs that we use that is non-opioid in page 220. Again, we use corticosteroids, your NSAIDs, such as your aspirin. But remember, for your aspirin, it should never be given to babies, to infants or children, because of its association with the development of a very serious health problem known as the Reye syndrome. This disorder often leads to mental deficits, coma, and death. So never give your aspirin to infants or children. Skeletal muscle relaxant. We'll talk about that in a little bit. And then antidepressant and then anticonvulsant we can use as well. So skeletal muscle relaxant, if you look at page 221, your table 11.5. So you have your methocarbamol or your Robaxin. You have your cyclobenzaprine or your Flexeril. Flexeril, this is also very common that we give as a muscle relaxant, but it can also help with the pain, right? So how does it work? Skeletal muscle relaxants relieve the pain associated with muscle spasms by slowing contraction signal transmission in motor nerves. So what are the nursing implications? Well, before we give the first dose of this skeletal muscle relaxant, you ask whether the patient has a seizure disorder because these drugs lower the seizure threshold. You check the dose of methocarbamol carefully because it's in grams, not milligrams. So very high risk for medication errors. You instruct your patient who are taking extended release tablets or capsule not to chew them, open, crush, bite, or cut to prevent rapid absorption of excess drug. And again, we already know, we instruct the patient not to drink alcohol or take any other CNS depressant. Okay, and then your antidepressant drugs that improve long-term sense of sadness can reduce some types of chronic pain and cancer pain, especially your neuropathic or your nerve pain, because of the tingling and then the burning sensations. So what are the most common antidepressant that we use for pain management? You have your amitriptyline or your Elavil. By the way, it's in page 223. You have your amitriptyline or your Elavil, nortriptyline or your Pamelor, paroxetine, another name is Paxil, and sertraline or Zoloft. So one thing to remember for your antidepressant, if we use it for pain, the dose of these drugs to manage the pain, it's different than the dose we use to manage the depression. But again, if you're giving this medication to manage the pain, you also have to remember the side effects and those things that we monitor for antidepressants. You remember those um, side effects and adverse effects that we monitor for antidepressants, especially the very most important one is the increased risk for those suicidal thoughts, if you can recall. So you monitor your patient, you're giving them something um, for pain, to manage the pain, but you're also giving them an antidepressant. So you watch out for those signs and symptoms or side effects and adverse effects that we look out for when we're giving antidepressants. Okay, lastly, your anticonvulsants. Anticonvulsants or your anti-seizure medication. Yes, we can give this also to the patients to manage the pain. Most of the time we give this again for your neuropathic pain, your nerve pain. Okay, and the two most antidepressants or anticonvulsants, I'm sorry, that we give is your Neurontin or your gabapentin and your pregabalin or your Lyrica. Okay, so going back to the slide, the action and uses, it acts at the level of the brain to control mild to moderate pain. So this one now is for mild to moderate. Before, when we were talking about your opioid, we said that that's for moderate to severe pain. Now this one, non-opioid, we use it for mild to moderate pain. And then we can use it in combination products for pain alone or when pain and fever are present. Side effects: sedation, dizziness, dry mouth, and constipation. Common adverse reactions that we look out for non-opioid centrally acting analgesics. You have postural hypotension, your dizziness, disorientation, euphoria and headache, lightheadedness, minor visual disturbances, sleepiness, slurring of speech, weakness, skin rashes, stomach or abdominal pain, dry mouth, nausea, vomiting, chills, difficulty urinating, and stuffy nose. And as I mentioned, these are the drugs that we use as non-opioid analgesia: your acetaminophen, corticosteroids, NSAIDs, skeletal muscle relaxants, antidepressants, and convulsants. And that is your chapter um, 10 or 11, I'm sorry.